very pleased to have Dr. Alexander Melinyshyn join us. Dr. Melinyshyn is an FRCPC neurologist with additional subspecialty expertise in headache medicine and a member of the Canadian Headache Society, CHS, and also a member of the Migraine Canada Scientific Committee. Dr. Melinyshyn operates a community-based headache medicine and general neurology practice in London, Ontario, and his current research interests include cannabinoid and psilocybin use in headache patients, as well as assessment of residency curricular content pertaining to headache across Canadian centres. He does this for the Canadian Headache Society. And with that, I'm going to stop sharing and turn it over to Dr. Melinyshyn.
Thank you very much. Okay, we'll get these slides up here. Okay, so I'm really excited to talk to you about something that comes up in my clinic almost on a daily basis. More and more patients are looking for multiple tools to put in their kit, not just relying on the classical pharmaceuticals that we use, but looking for other supplements that they feel are more natural or maybe are kind of a less side effect prone option that they can kind of dip their toe in terms of migraine treatment before they go on to heavier things. And so I think this is something we all spend a lot of time counseling about in Headache Clinic, and I'm excited to share with you kind of my approach to how we talk about vitamins and nutraceuticals for migraine. So in terms of disclosure, I get some grants and research support, both from the Canadian Headache Society, my fellowship was funded through them, as well as some research grants. I do a number of clinical trials that are some of them industry-led, some of them I get to initiate myself and design everything. And so I'm really involved in the migraine space. I take part in a number of different advisory boards where we learn about all the up-and-coming data, and we try to argue and haggle about how this could best help our patients and where new drugs fit into the treatment algorithm. And I give a lot of talks like this, whether it's to pharmacists, nurses, nurse practitioners, GPs, neurologists. I'll talk to anybody who will listen about migraine because we're trying to increase more awareness, as many doctors actually do not receive a lot of training about headache, which was another focus of my research. So just to kind of emphasize what has already been said, anything that we present here, these are mostly my opinions. So a lot of it is kind of based on gray evidence, which is not kind of high quality, double-blind, placebo-controlled trials. But a lot of it is born out of clinical practice and things that are handed down from our mentors as we train, and just experimenting with different patients who have different types of presentations, especially when the things we usually recommend have failed. So for tonight, we're going to focus on a couple things. We're going to briefly touch on the role that these migraine preventives that are nutraceuticals and vitamins play in terms of pathophysiology. And that means understanding how it actually interacts with the mechanism of migraine. It is vastly complex, and we're not going to be able to go into the very nitty-gritty today, but I'll kind of paint with broad strokes and tell you what's going on. We're going to talk about the evidence behind these, which unfortunately is quite sparse. We're going to talk about safety, efficacy, and potential side effects with these, just to make sure that you're being doubly safe when you consider one of these options, and talk about how you can integrate this into your treatment plan in terms of potential doses and things like that. So I want to start off just by giving a quick shout out to the new Canadian Headache Society guidelines. We've been waiting with bated breath for a long time. The last edition came out maybe 2012, and it only really covered episodic migraine. But the new guidelines actually both address chronic and episodic migraine, which is important. And some of the items, which I've marked here in an X, are kind of still standing recommendations from the old guidelines. And then they reviewed all of the current literature on the new options to make sure that we have a comprehensive picture. If we're boiling it down just to very simple kind of terms, I have a lot of friends in neurology and primary care who say, okay, look, if I just had to memorize 2 drugs for each kind of indication, which I always joke is like the kind of Martian approach. If you're going on a long duration space flight and you can only take so many things with you, you better have 2 things for each problem. So if we're looking at episodic migraine, the ones that really came ahead with the best recommendations would be beta blockers, the TCAs like amitriptyline or nortriptyline, and then candesartan, which I think has become a darling of all the headache experts because it's very well tolerated, and low doses tend not to drop your blood pressure too much, even if you have normal pressure. On the chronic migraine side, really the mainstays of the orals are propranolol and topiramate. But of course, these newer agents that have come, Botox and the CGRP antagonists, we think they're generally a lot better tolerated. They seem to work as well or better. And so it's become the opinion of a lot of headache experts that maybe these other drugs should be considered first line. So then that takes us to the naturals. I get a lot of people that tell me, I don't want to take your toxic chemicals, which is a fair thing. And they want to try something else first. And what I would say is, organic means something very different to a scientist than it does to the general public or someone buying groceries. And that's because we think of organic chemistry, and the difference between inorganic and organic means you have a carbon backbone, and there's certain types of complex molecules that make something organic. So like I remember I had a chemistry professor who said, "I challenge you to show me inorganic lettuce," like it would be kind of funny. But the term has become loosely used to apply to a lot of different scenarios. And so in our minds, we're taught to think this means it was grown on a farm with no pesticides and, cared for properly. But in reality, it is quite a slippery term, and it's not regulated, perhaps, with a lot of fraud. And so because there's a huge price incentive to purchase organic options, you see the space being crowded by a lot of kind of shady dealers. The other thing I would emphasize here before we go deeper is that natural doesn't necessarily mean safe. I think we've all been heavily marketed to psychologically to think that natural is the more useful option because it lacks some sort of toxicity or something. But I would argue that there's a lot of things in the natural world that are toxic. Snake venom, spider venom. We've got lots of plants that do all sorts of bizarre toxic things. And most of the molecules that form the backbone of our modern pharmaceuticals come from plant-based sources, or at least the idea of their chemistry was inspired from molecules from them. So, I would say, it really is something to think about. A lot of the reason we use synthetic chemistry is to take away the negative aspects of these natural molecules. The other thing I would say is that, chemicals, the word chemical has become dirty. And again, to a chemist, this doesn't really make sense because all things that we touch are made of chemicals. Everything is made of chemicals, the fundamental building blocks. And so everything you eat is technically a chemical of some sort. Chemical does not necessarily mean bad, okay? But the reality in our society is that, yes, our food supply chain is contaminated with a lot of things worldwide. Sometimes things are cut with products to save money. Sometimes we add a lot of unnecessary chemicals for preservation or to increase the flavor or texture, which keeps you addicted to food and eating more. So there's some questionably necessary ingredients that perhaps should not be there. And the truth is, the food industry itself regulates the addition of these items. And so perhaps there could be unforeseen pharmacologic consequences. And food supplements or additives are not regulated the same way that pharmaceuticals might be under greater scrutiny. So why do we need vitamins and nutraceuticals for migraine? Many people are worried about the potential side effects of medications. Others worry that they're not getting everything they need from their diet, when in truth, most of us are probably getting our required nutrients in North America, as long as you're eating a balanced meal twice a day or 3 times a day. The current evidence that we have doesn't really support the use of a multivitamin in an otherwise healthy person in terms of prevention. And so there was an article even from the CBC that said, oh, I don't know, maybe the vitamin pill should be avoided. This is based on an editorial from an American doctor. But what I liked about his letter was that he highlighted a number of really important big studies, and these were when I was actually coming through medical school, they came out, that said, they probably aren't justified. And we spend quite a huge amount of money as a continent on vitamins. And the joke is, you'll hear it probably, is that, we have the most expensive urine on the planet. And should we be focusing this energy and money on other initiatives that might be better for prevention? And I think that's a valid argument. And so Dr. Apple discussed a number of different large studies that kind of showed that in certain contexts, the vitamins really didn't play a big role. And so one, for instance, the U.S. Preventative Services Task Force, they every so often come out with recommendations. And at this point, they were looking at, if we look at community dwelling adults who don't have any known deficiencies in vitamins, like, is it worth supplementing these vitamins? And they included a number of trials in this analysis, including 3 trials of multivitamins. There were 24 that looked at single or paired vitamins in different combinations, and it included over 400,000 patients. And after looking at all these studies and cases, they found there wasn't some clear benefit on all-cause mortality, heart disease, cardiovascular, or cancer. The Physicians' Health Study also came out in the same year, and it looked at daily multivitamin versus placebo, this time looking at the effect on cognition and dementia. And it included almost 6,000 people over the age of 65. And after following them for more than a decade, they really didn't see any significant differences in the groups between overall cognitive performance and verbal memory. And, this study, because it looked at some people who are kind of medically literate, had a very high rate of adherence to the treatment and very precise estimates. So I think that's a pretty strong case there. And then a third trial looked at the trial to access chelation and therapy. This one was looking more in the context of cardiac disease. And so they followed over 1,700 people who had had previous heart attacks. And almost for 5 years, there didn't seem to be a significant separation between the groups. So I think for those conditions, at least, the multivitamin or other vitamins don't seem to play a huge role. But I do think there's still some arguments to be made for specific deficiencies, and perhaps in the context of migraine, which we're going to see. So, do Canadian adults meet their nutrient requirements through food intake alone? I think that's kind of the natural next question. Like, do we have these deficiencies? Should we be addressing them? Should we be screening for them? And just to highlight from the study that was done as a government trial study, I would say the major takeaway findings here were that calcium, magnesium, and vitamin D were the major things that Canadians tended to be lower in terms of dietary intake. So more than a third of Canadians over the age of 19 consumed magnesium below the threshold requirements. And then if you look at the adults specifically, this rises to more than 40% of these people. And the one thing I would say, the vitamin D has an asterisk there because vitamin D is unique. This is one of the vitamins that you can synthesize yourself if you have adequate sun exposure. And we're going to talk a little bit about that later. So maybe the dietary vitamin D isn't necessarily the most important thing as long as you're getting a good amount of time outside with some skin exposure. But if you aren't, it might be a smart idea to supplement it. So I would say, from my perspective, and what I tell my patients, is that the best bang for your buck seems to be focusing on magnesium and vitamin D levels. Foods that are rich in magnesium, like everyone loves avocado, you can do edamame or black beans or something, quinoa, almonds, a lot of nuts like cashews and peanuts if you're not allergic, and dark chocolate, which I know migraineurs tend to avoid. But I would also, maybe a time for another talk, maybe chocolate should be back on the menu. So if you had to pick between your vitamins and pharmaceuticals, I mean, personally, I would tell you get outside, get some sun exposure, eat a balanced diet, and focus on lifestyle. I think that is the firmament, the first block that we have to focus on with patients. And when that isn't working, it makes sense to progress to other interventions. A question we hear a lot is, I heard, natural products and supplements aren't regulated the same way as other pharmaceuticals, more like food. Are they safe? And this was an interesting editorial that came to the CMAJ, which is our journal for the Medical Association in Canada. And this is Dr. Junak, who is actually a functional medicine practitioner. And she wanted to say, there's been a lot of myth around the regulation of natural supplements, and people think that they aren't regulated or contaminated. And, this has been true specific times historically. And to this day, some specific supplements have variability, and we'll talk about that later. In theory, though, I think what she wanted to emphasize was that they are regulated under the law. And she rightly points out that they're regulated by Health Canada under the Natural Health Product Regulations. And, also, in particular, there's certain places where we import supplements. And so in particular, China or India are known to contaminate supplements with heavy metals or undisclosed pharmaceuticals. This could be mahuang or ephedrine-containing compounds. It could be steroids. In some dietary supplements, even pablum, we've heard complaints of melamine, cutting it with melamine or lead. And so it behooves you to do your own personal research about where your foods are coming from, understanding the supply chain of where they come from, and making sure that you're getting a good, safe source. And then, the next thing that came along was Bill C-47. And I think this is an important next step if people are to continue to have faith in natural products. And this is in an effort to kind of harmonize the regulations between natural products and supplements and pharmaceuticals. And so once this is properly implemented, it really should be regulated on the same par as what we would consider standard pharmaceuticals. So why do we need the vitamins and nutraceuticals for migraine? I mean, the secret is that, I actually want you to get better. I think, if you look around, you're going to see people on the internet on TikTok and everything, we kind of laugh like, how many things have you seen? Like the secret your doctor doesn't want you to know about belly fat, the secret your doctor doesn't want you to know about migraine. I think this is very predatory marketing. I think all of us at some time, whether it's with religion or political ideas or conspiracy theories, there is this idea to kind of, perhaps I have some secret knowledge that circumvents, the conventional wisdom, and that they're trying to keep you sick to make money off of you or something. Like, I actually want you to get better. Most of us put our lives into these jobs that, frankly, are quite difficult and, not easy jobs. And we're spending every day listening to people and helping them work through their problems. And frankly, like, I mean, if you knew, your doctor makes $38 to see you in a follow-up, and when you don't show up, which is like 30% of people, you don't get paid. So, I mean, if we really wanted to make money, we'd probably be one of those influencers who are selling you vitamins on, on YouTube. So, I think that's the true reality. And the more reasonable rule of thumb, I would say, is that anything that's potent enough to cause a significant unique benefit is probably potent enough to cause harm. And I think there's an ancient quote from Paracelsus that anything in the right amount is a medicine, and anything in the correct amount can be a toxin. And that's true even of water. And that's why we use the pharmacologic sciences to tweak molecules to get you the most benefit from something with the least harms at the right dose for the most amount of people. And that's the whole point of clinical trials. And the other thing I would say is that, if the natural options worked really, really well for everybody, like, we probably wouldn't have gone down the very laborious and cost-intensive process of developing medical sciences and synthetic chemistry. The nutraceuticals effect, while for some people they can be quite profound, in reality, I mean, the size effects, if we look at a population level, are very small compared to the usually recommended pharmaceutical options. So I tell patients, this is totally a reasonable place to start, but I'm here to offer you the medical advice when you're decided that it's time to go further. So what is recommended for migraine? If we go back to our guidelines, you can see butterbur, riboflavin, CoQ10, magnesium citrate. These have good evidence in episodic migraine. Melatonin, which is, become quite a darling of many different practitioners, whether it's for sleep or cluster headache or migraine, it's got a weak and very low recommendation, and you'll see the evidence is not very good. And we'll talk a little bit later about why it may not even really be good for insomnia, but rather for circadian shift disorders. Feverfew, which is often touted by naturopaths, actually has a strong recommendation against its use in episodic migraine because of poor trial data, and it doesn't seem to be much better than placebo. On the other side, for episodic migraine, some people talk about ginger, whether it's regular ginger teas, eating raw ginger, powdered ginger, as a preventive, but, we'll see shortly later why I don't recommend that for my patients. So without further ado, we're going to jump deeper into the meat of our talk and examine some of our options more closely. If you go to a naturopath or a neurologist or another headache specialist, you're going to often get this kind of stack of vitamins. You're going to pick one kind of magnesium, riboflavin, vitamin D, CoQ10, and maybe they may offer you petasites or butterbur. And I think these are kind of the standard ones. And I tell my patients, like, there's no need to rush into this and eat a whole handful of pills every day. Maybe start it for a couple months and watch one at a time and gradually increase it here, the way we've described. And then if you think it's working, keep it. If it's not, maybe you dial it back and you get rid of it. And then you can add them one at a time. So let's cross this one off the list, ginger. There was only a very small study, like there aren't a lot of good controlled trials for most of our nutraceuticals. And this one compared 53 patients on ginger on a regular dose of capsules to placebo, done in a clinic in Brazil. And they followed people 18 to 60 years old who had episodic migraine. They were not taking any other prophylactics, and they followed them longitudinally. And at the end of the study, they counted all the pills to make sure people were taking the pills. So really only the people who actually took the ginger were included. And unfortunately, they did not see any significant difference between both groups. Both actually improved. So both the placebo group and the ginger both dropped in terms of their number of headache days and the severity. But, this is very common to pain trials. As you'll see if you look at the data for any of our pharmaceuticals, placebo responses in pain trials are very big. And that's a topic for a whole other talk. So from our guidelines, I would say this is not recommended for use in episodic migraine. I mean, maybe it helps you with nausea. I think it could also be a wonderful placebo, but frankly, it's not something that I routinely recommend. Magnesium. So this is going to be the meat of it, and this is probably my favorite of the nutraceuticals. Magnesium is a very complex and fascinating element in your body. It's extremely important. So it's probably the second most abundant cation, which is a positive ion, after potassium. So when an atom loses an electron or gains an electron, it becomes ionized, and this is what an ion is. It has many, many physiologic and biochemical functions. It's involved in enzymatic processes, over 600 of them. Most of these are ATP dependent, which is like the main energy currency of your body, but it does everything from like degrading macronutrients, oxidative phosphorylation, which makes energy, the synthesis of proteins and DNA. It helps determine the excitability of your neuromuscular membranes. It's involved in synthesis of parathyroid hormone. You could go on. The list honestly goes like 500 items. So I would say this is a really important element, and being deficient probably leads to a myriad of diseases. The normal serum range that's quoted by the Medical Council of Canada is somewhere between 0.7 and 1.03 millimole per liter. And so what is magnesium doing in the context of migraine? And I think if you're boiling it down to a very simple kind of level, I think it helps to understand the brain and the way it communicates between all the neurons in terms of uppers and downers. And if we're thinking about the main inhibitory neurotransmitter, we talk about gamma aminobutyric acid, which is GABA. And if we're talking about the main excitatory transmitter, we're talking about glutamate. And GABA acts at the GABA A and B receptors, which also alcohol acts at. And, some of these receptors are targets of gabapentin and pregabalin. Glutamate acts at the NMDA receptor. And you may have heard some interesting research about ketamine of this receptor. And so it's very simplified, this picture, because there's actually quite a few different neurotransmitters. These are the main ones, and they're all in a constant flux of balance, uppers and downers, depending on what we're attempting to do and various states as you react to your environment. This is the NMDA receptor, and it looks a little bit complicated, but you can see here that there's a pore, which is the center of this core. You're looking at it cut down the top, okay? And the membrane there, those little circles, is the cellular membrane. And so this receptor is kind of spanning across the surface of a cell, and it lets ions through, those kind of particles, the atoms that have changed their charge. And so we rely on a balance of all these different pores on your neurons to set the tone for whether we trigger an action potential, which is the electrical impulse that your neurons use to talk to each other. And so this NMDA receptor is very specific for magnesium and calcium, in that magnesium usually blocks this pore. And at a certain voltage, the channel is closed regardless. When an action potential forms by, maybe the channel opens up, but magnesium is still plugging that hole. And then you rely on a different change in potentials to have magnesium leave that hole, and then calcium is free to pass through. So it's like two-step process to get past the checkpoint. So magnesium blocks the calcium channel in the receptor, and it must be removed for that excitatory signaling to occur. So low levels of magnesium, like if you didn't have that blocking it, calcium is free to go willy-nilly back and forth through the channel once it's open. And so we think that potentiates the glutamatergic neurotransmission. This is excitation, so too much positive, too much activation, and that leads to toxicity. Like if you're too excited and you're using up too much energy and you can't turn it off, like that's not going to be a positive thing. That leads to oxidative stress and then eventually neuronal cell death, so it's an unhealthy situation. And then on the low magnesium, we think because it's hyperexcitable, you can't shut it down. This leads to cortical spreading depression, which is that kind of spreading excitation across the surface of your brain. That is not enough to cause epilepsy, but maybe it's enough to trigger an aura, and you can have visual symptoms. And separate talks that Migraine Canada has addressed kind of the relationship between aura and migraine. And so we think that low magnesium is a very interesting clinical target for migraineurs. Not just unique to migraine, I would say low magnesium has been implicated in other chronic pain conditions like fibromyalgia, epilepsy, Alzheimer's, Parkinson's disease, stroke, and also psychiatric conditions like depression and anxiety. And if you've spent any time around a headache clinic, you'll know many people have more than one of these diagnoses. So magnesium in English, I know there's a lot of jargon there. Basically, magnesium helps to dampen down the tone of your brain activity. So when you lose it, the brain gets overexcited. And then this leads to more auras and lowering that threshold that you trigger the migraine. It may also contribute to a whole host of other neurologic and psychiatric conditions. So, because magnesium is so ubiquitous, it's found everywhere in your body, it's involved in so many different processes, it's complicated. This is a fertile ground for lots of people who take kind of grains of truth and make a lot of different claims about what magnesium can do for you. Often they will focus on one clinical study done in 5 rats, or we had some stem cells in a dish and we did some things in magnesium. And then they extrapolate this to why you should buy their special formulation of magnesium for $200. And so this doesn't necessarily translate to humans day to day. And that's why we need clinical trials, because there's many steps from that in vitro experiment or the rat study to extrapolate all the way to humans. Many, many pharmaceuticals that we thought were useful in rodents or apes or something, didn't make it to the final clinical trials because there are fundamental differences between us. If we look at the CHS guidelines and you dig deep into the trials they actually looked at to make their recommendations, there are, these studies are a little bit stale. So we're taking studies from 1996 and 2008. And, they were quality studies that suggested, there may have been a signal there. But I think, a lot has happened since then. And so it might be reasonable to look at some newer stuff. So we're going to look at some studies that address the question, are all the magnesium created equal? So this study, magnesium and migraine prophylaxis, they wanted to know, like through a systematic review, is there any kind of rationale to use magnesium? Because in common parlance, we all recommend it quite often. And they included over 204 search results that found 5 clinical trials fulfilling the criteria. So when you look at the criteria for a systematic review, you want to make sure that the trial is designed appropriately. You decide whether it's blinded. You want to make sure that they had good reporting and not too much dropout. And so you set these criteria ahead of the review so that it's unbiased. And then you comb all the literature to pick up the best studies. And so they said, well, it's grade C, possibly effective based on what we have. And so, interestingly, they said specific formulations like magnesium dicitrate seem to be cost effective and it seemed to be a useful strategy. They said in reality, there's very limited evidence in terms of how big the studies are, how they design them for blinding, the quality of these in terms of collecting the data longitudinally. And then it really gave kind of a mixed picture. Some of the studies were very much in favor of it. Some of them said, I don't know, I don't think there's a benefit. And the authors commented, they said, well, if we parse the magnesium by the type of magnesium, there's an interesting distribution there. And they said, we've noticed that there seems to be a big difference between the magnesium citrate, the trimagnesium dicitrate, and then the carbonic acid and aspartate hydrochloride. To boil this down, they're saying, okay, there's organic forms and inorganic forms. And the organic forms are kind of nestled within this nice carbon lattice of some kind of acid. And the inorganic ones are more elemental types of magnesium. And it seems that your body is more readily able to absorb the organic forms. So that was kind of an interesting study there. This next one looked at the type of magnesium salt to kind of further address that question. And does the solubility determine the bioavailability? And again, they reached an interesting conclusion here. They said magnesium glycerophosphate and bisglycinate seem to have a higher bioavailability compared to the inorganic salts. And they showed this also in a graph here. So you can see that bisglycinate and glycerophosphate were much higher than the inorganic ones like chloride, carbonate, or oxide. So there's some couple issues here. Like, first of all, they were just measuring serum magnesium, so just what's in your blood. And your body's formed of many different compartments. You've got compartments of different organs. You've got compartments of adipose, the fat tissue. You've got your blood and your serum. And the brain itself is a very privileged space that's, blocked by a blood-brain barrier that is meant to kind of protect your brain. It's very sensitive from all the things circulating in your body. So serum magnesium is a good proxy for bioavailability. It's one of the best things we have to measure it, but it's hard to kind of see how the magnesium is being used in different tissues. And that might be a good thing to know if you're targeting, for instance, a disease of the central nervous system. So what they found was that the bisglycinate and glycerophosphate were more available. The next study, and this was kind of another review article, a lot of these are not independent new research, but they're rather taking up all the kind of small articles that people have done and trying to analyze them in a comprehensive way. Um, this is kind of reflecting that we have this tone, like there's more and more evidence to think that magnesium plays this really important role in a lot of different neurological conditions like we talked about. And they said, well, based on our review, it seems like this one type of magnesium is gaining more popularity compared to others, and that's magnesium threonate. Sometimes people call it brain magnesium. And what's interesting about it is that it seems to have more permeability of the blood-brain barrier. So some magnesium, a lot of the elemental ones, don't even make it past the bowel. So that's like oxide, chloride. So you want the glycinate or the citrate. But then if you're comparing threonate and glycinate and citrate, you get more accumulation in the CNS within the brain and spinal cord compared to other forms of magnesium. So what I would say is that we don't have a lot of great evidence, but what we can tell you is that all magnesium supplements, regardless of the type, seem to maintain physiologic levels in your blood. Okay? Organic magnesium forms are more bioavailable than the inorganic ones, and the tissue distribution, whether it's going to your brain or other tissues, depends on the form administered, with threonate kind of being the leading one for CNS penetration. And so even all my patients, I explain this, the best I can to try to stay neutral. And they say, well, come on, you got to just tell me what's the best one. And I don't think the answer is really that simple. Um, but there's a website that I really like, and I would also direct you here too. It's kind of like an American version of Migraine Canada, and they often have very good complementary articles to the materials that we're making with Migraine Canada. So I often go on Migraine again just to see what people are thinking. And they had a recent article where they said, well, which magnesium is right for you? And they kind of extrapolated from a lot of different studies to say, well, this one's better for fibro, like malate, or, this one is better for constipation and heartburn. And so there are some little case series and studies that support each of these specific indications. But again, the quality of the evidence isn't what I would expect from other pharmaceuticals. And it's not really recommended for prevention, or sorry, it's recommended for prevention rather, but not really for acute use. So you're not taking it just as needed, because to absorb magnesium actually takes quite a bit of time. So it's not a very effective abortive unless you're going IV. So the exception to that is if you're in a hospital, sometimes your doctor will give you IV magnesium as part of a treatment for migraine. The difference between the types is probably not large, with some exceptions like the threonate that we talked about. So what I recommend in my practice, I kind of highlighted here, I would say if you're looking for cost-effective and maintaining your serum levels, citrate and glycinate are kind of my go-to options. Others may be just as good, but this is kind of the voodoo that I've developed over the years. And then threonate has kind of become my specific one for people that I talk about with brain fog and vertigo, and it's more CNS penetrating. So you might try with the cost-effective ones first, and if that's not really working out, we may try these other ones. But for many people, the cost can be a barrier. So in terms of the doses, I've listed kind of my recommendations here. As a caveat, like I've listed some doses that kind of go beyond the gray area. Like I think most guidelines would recommend that you don't exceed the 400 milligrams per day of magnesium total, unless you have some sort of deficiency and your doctor has told you to go higher. Because magnesium can be toxic if you go too high. The other thing to remember is that magnesium should be used with caution in people with renal failure or kidney disease. So ask your doctor about that. And if you go too high, some of these preparations do cause diarrhea. Like if you think of milk of magnesia, magnesium citrate, it's an old-timey constipation remedy. So if you go too high, you're going to know. And so I tell my patients, go up slowly, and if you feel bloated or crampy, you go back down to the last tolerated dose. If you want a great review on vitamins, this one's a little bit older, but I like it because I don't think it's behind a paywall anymore. And so it's a pretty good analysis that's in pretty plain language if you want to kind of dive into that. There's actually a newer article that just came out a few days ago, I think on the 25th. But I think it's a little bit costly for people. But if you want to access that, I'll leave that in the references at the end. So the main takeaway from the magnesium, I love it. I use it often. The effect size is small. For some people, it can be a very helpful adjunct, something to add into your regimen, but more research is needed to really determine the optimal formulation and what dosing we should be using. On to riboflavin. So riboflavin is vitamin B2, and there's a whole host of B vitamins, and so they all have different names, but they all do something different. And in neurology, we have to memorize all the different deficiencies because they present very strangely. And riboflavin, it has an important function in terms of reducing oxidative stress. When it's deficient, it can cause mitochondrial dysfunction. It causes inflammation. It leads to more glutamate excitotoxicity, like we already talked about with magnesium indirectly. And so all of these things have already been implicated in migraine. And so I listed a review article here that if you want to delve deeper into the critical functions of riboflavin and how it's linked to migraine through that kind of neurotoxic cycle, this article gives you a very good overview of that. Oops. There we go. So does deficiency cause migraine? This is a kind of cheekily worded article, to be or not to be, B2, and they wanted to do a quick systemic review on this. And the other issue I have, just as a caveat, we're looking at a lot of systemic reviews in this talk because the evidence is sparse, the trials are small, and so they're looking to scrounge up everything we have. But one thing you have to keep in mind is that a lot of scientists and doctors do not publish negative trials. So there's a publication bias, they call it. And so if you have a trial and you did all this work and you didn't really get the conclusion you're looking for, some of them don't bother to publish, or the publisher may say, why am I going to publish this article? It looks like it's a lousy pill. But the trouble with that is actually we should be publishing every negative study, because when we go to do a big analysis, like a meta-analysis or a systemic review, if you only publish the positive articles, it looks kind of good. But you're missing out on all the actual times we tried it in different contexts where it didn't work. So I always tell people, take kind of meta-analysis and systemic analysis with a bit of a grain of salt, but it's still valuable information. So they were able to find actually 2 articles that were able to meet their criteria. So not a lot of evidence, but they found that elevated dietary consumption of riboflavin reduced the chances of migraine in that group. And so that was kind of interesting. But our riboflavin recommendations from CHS, again, they're kind of some of these trials that were included in that as well. They aren't particularly profound, but they're enough that I think it's possibly or probably effective. And so the authors commented here, they said, well, despite all the evidence from these trials, clinical experience with riboflavin is pretty disappointing. And I would say that most of the headache experts who see this in our clinic agree. There seems to be a pretty minimal prophylactic effect. I mean, the cool thing is it turns your urine neon yellow and it smells funny, and people often think it's a urinary infection, but in fact, you're just peeing it out. So the CHS guideline recommendation gave it a strong recommendation of low quality evidence. So you can recommend it to patients who are eligible for prophylaxis. There may be some evidence. The side effects are minimal, so there really isn't a lot of risk to it. So have at it, and if you think it's helping, then by all means. So here's the dose that we typically use. You may also include it as part of your multivitamin, so double check the label to see how much you're actually getting in it. The next one is CoQ10. And many people have not heard of CoQ10. It's kind of an interesting one. I think it's pretty fascinating. And oh dear, how did this happen? Oh, well, one of my slides got somehow changed in the format. What I wanted to show you was that inside a neuron, you have a whole bunch of, I would say, mitochondria, which are these little sausage-shaped organelles, and they've got these folds within them called cristae. And these fascinating pieces of your cells actually are ancient proto-archaea bacteria that we absorbed into our cells, and then they just became part of us and they replicate with us, but independently of our own DNA. They produce all the energy that we use for cellular processes. And the main currency is called ATP, which is adenosine triphosphate. And you break off one of the triphosphate, means you have 3. You break off one of those phosphate and that releases energy, and then we recycle it back. And that cycle is what gives us the energy currency. And so CoQ10, unfortunately, you can just see it there on the edge of the slide. It's a cofactor in this long chain. So within the mitochondria, embedded in those folds, you have these different proteins that help to kind of pass electrons along this transport chain, they call it. And eventually you're taking all the energy that you're absorbing through food and different processes, and you manage to pop it into the ATP. So you're kind of converting it into this different currency. And so if you don't have CoQ10, or it's deficient, or it's damaged, or there's some other issue, you're going to have altered ATP to ADP ratios. You're going to have lower energy. Your cells are trying to scrounge for energy in different ways, and they're eating up things that they shouldn't for other processes. And you end up with dysfunction, oxidative stress, and inflammation. And so you're going to hear this kind of repeated theme of oxidation, inflammation, glutamate, excitotoxicity. And so all of these things that we're talking about as nutraceuticals tend to play some role in this chain, and that's why they were considered. So the CHS guidelines, still in effect from 2012, of course, only had one real fair quality study that looked at CoQ10. And after a month of placebo baseline, the patients were either put into a group with 100 milligrams 3 times a day or placebo. And again, maybe a modest improvement. So, generally comparable groups that seem pretty balanced. So I think it's a fair quality study. And I would say CoQ10 in my practice clinically is a silver bullet for some people. And for other people, it does absolutely nothing. And what that suggests to me is that what we're calling migraine, the phenotype of migraine, it's a clinical diagnosis. You're telling me you have a throbbing headache with nausea and vomiting, light and sound sensitivity, and you get worse with exertion. That's the final manifestation at the end of the pathway. But there may be 100 roads that feed into that. And so maybe one of the roads is mitochondrial dysfunction, and maybe they have some sort of deficiency in CoQ10. So again, it's pretty well tolerated, maybe a little bit of dyspepsia in some people. But I tell people try it out, and if you don't think it's working after a couple months, you can get rid of it. The next one that's up is a pretty interesting one, and it's Pedicides butterbur, and this has had a bit of a storied history because there was a point in time where a lot of doctors got turned off by this medication because there were some toxic indoleamine chemicals that were actually causing fatal liver damage. So it would kill your liver, and you'd need a transplant, or you would pass away. So that, made people understandably a little bit hesitant. But this was from poor manufacturing process. And since then, the process has been extremely refined. It's extremely safe. There are certain brands that you can definitely trust. And whereas there are still some where you're like, well, they ran some tests, and actually some of these pharmaceuticals do not contain even 10% of what they claim to contain. So I would say one brand that truly they sponsored this talk, but they're not, influencing me unduly. I think this is the one that after reviewing their safety data, I feel like this is the one that I recommend to my patients more often. It doesn't need a prescription. So it's considered that safe that, it's not regulated in that way. And you can take 75 milligrams twice daily. You take it with meals to prevent any gastric upset, and you try it out for a couple of weeks. I tell my patients actually to take it for a month. And it's meant for episodic migraine. And I would say, the patients who tend to respond most are those who have kind of low frequency episodic migraine. And it contains a couple of other things I included here for those who have sensitivities. So what are the Pedicides? So they're this genus of flowering plants. They're related to sunflowers, tournesol, and they take extracts from the roots, the leaves, and the flowers in antiquity, and it was used for all sorts of things, for head discomfort, antispasmodic, as a painkiller, So it kind of made sense to extrapolate this from the ancient pharmacopoeia to use for migraine. But I would say the preparations we're using now are probably a lot safer than what we were using in the Middle Ages. So the thing you have to remove from there is those pyrrolizidine alkaloids, and those can actually be very toxic to your liver. And so I would say I have pretty solid confidence in the process now that it doesn't have this function. And our CHS guidelines actually look upon this drug with quite a favorable outlook. So I think it has pretty good quality assessment. It's been assessed in 2 good trials, one by Dr. Lipton and the other by Diener in Germany. And I would say that, like I said, it's effective in those who have kind of the lower frequency of migraine. All the butterbur species are not the same for migraine relief, so you can be pretty confident that this one in particular has the full 75 milligrams. But the other formulations may contain different versions. So the plants that come from other locales globally may not have the same amount of active ingredients, and so it varies. So I would say off-brand versions of this may contain the alkaloids, some of them. And so that's kind of dangerous. And they don't always contain enough of the active ingredient, even though they claim to. So I would say this is one that kind of, I don't use it often, but when I do, this is the brand that I pick. So this is just a quick thing to show you that at least 15% of the active ingredient is pepsin and isopepsin and contains no harmful alkaloids. And that is the recommended dose that you would recommend. So no prescription required. Great for those with low frequency migraine. And then you would maybe think twice if you were breastfeeding or pregnant. This is not something that you could continue in that context. Any allergies, obviously, which is what we say for any drug. People who have kind of liver disease are at high risk with alcoholism. And if you have any signs or symptoms of liver disease while you're using it, you really should stop this immediately and talk to a healthcare provider. But truthfully, that's not likely to occur. So I would say it's an interesting option if you're considering it. Maybe speak to your practitioner and see if this is something they might recommend or if it can jive with your other medications. So from our guidelines, feverfew may be effective for prevention, but in the absence of a lot of clear safety studies, the difference in doses and characteristics of preparations, and the myriad of all the different extracts suggest caution for recommendation for use. And so to cut through that, I would say this is the one that I actually do recommend. And I was joking with Kaylee, like I don't often recommend one brand in a crowd of things, but this is the one that I actually feel safest with. And then sorry. We moved already from Butterbur to feverfew. Sorry, I just blew a mind blank for a second. So feverfew is the other herbal remedy that we talk about, and in fact, this one we do not recommend. So I want to pedal back on that. And in the trial that we do have, suggests it's probably no better than placebo for the prophylaxis of migraine. So in fact, feverfew is often put in a lot of those combo pills that you see on Amazon. I really don't think it's helping a lot. So this is not one that I recommend often. Melatonin. So this is something that's extremely popular. People are often taking it for insomnia. I've listed just a handful of some of the purported benefits of this. It's anti-inflammatory. It, scavenges free radicals. It affects the interleukins and cytokines that govern our inflammation. It affects nitrous oxide, which helps to dilate blood vessels and is important in pain transmission. It affects dopamine, our neuronal membranes, GABA and opioid analgesia, glutamate, so you can go on and on. It's very interesting. And I think because it has so many mechanisms like magnesium, it makes it kind of a molecule of interest. And so people have been drawn to it. And I would say the main role from my perspective is that it's involved in circadian rhythms. These are your daily rhythms, which is in an area of your brain called hypothalamus. And the hypothalamus is like your thermostat. It's trying to govern homeostasis, which is the idea that your body's always trying to maintain the same conditions within it for optimal function. And so it regulates hunger, thirst, sex drive, sleepiness, is kind of keeping all these things in check. And in addition to the daily cycle, there's actually a circannual rhythm where it actually has a rhythm throughout the course of the year. We have interesting studies that show the hypothalamus may be before a cluster or a migraine attack, even a few days before. So, if you have a medication like melatonin with very few side effects and it seems to act in that area, it makes some logical sense to try it, perhaps. Perfect. So, I would say melatonin for me in my clinic is sometimes recommended, especially in the setting of cluster headaches or other TACs, the trigeminal autonomic cephalalgias. These are the family of cluster, the rare variants. And I wanted to highlight for you the interesting thing about melatonin is that it shares some chemical structure. So we call these stick diagrams the Kekule structures. And this is how organic chemists will convey, molecular structure. And if you look, there's this, pyrrole ring and benzene ring that are conserved between serotonin, melatonin, and triptans, which we know are effective. But it's the functional groups, those little extra dongles on the sides that really determine the chemical activity. And each receptor is like a keyhole. And, if you have a key that kind of fits, maybe it can activate it to some degree or do something different. One thing I want to highlight, and this is controversial, like actually I know a lot of sleep specialists who actually love melatonin for insomnia. But I would say if you're towing the official party line, you'll say melatonin is not for insomnia. It can produce phase shifts in the circadian rhythm. So that rhythm of your day and night cycle is useful For instance, if you're switching from days to nights on shift work or vice versa, or if you're flying across time zones and you want to resync your clock. So the thinking is that, well, it syncs up the clock and sleepiness, but it doesn't really improve the sleep quality or the architecture. So I think that would be kind of the official thing. But it does make a great placebo, and sleep is extremely psychological. I would say actually the most things that I focus on with my patients to start is sleep hygiene. So instead of just throwing you on a sleeping pill right away, I think we should be focusing on healthy behaviors around sleep that gets your body in the right phase to fall asleep. Sometimes people, despite that, still need something. I tend not to use benzodiazepines at all. I try to avoid the Z drugs, the trazodone, zapaclone, esopaclone, because there's habituation and they become dependent. And so maybe you could talk about other new options. There's many new drugs actually that have come recently you could talk to your family doctor about. So I would say for evidence-wise, melatonin has one maybe short, small study for 2 months. 2 milligrams of melatonin was negative versus placebo. Another study that we had 3 arms, they compared it to amitriptyline, placebo, and melatonin. I mean, it was pretty comparable between the groups, but the amitriptyline, I think, maybe did a little bit better. But not a lot to go on beside anecdotal reports. And so it's not something that actually it's kind of fallen a little bit lower in my recommendation of the list. One thing that I would caution with melatonin, like this is one thing that actually kind of gives me a little bit of pause. There's a study that looked at 31 different supplements selling melatonin and the lot-to-lot variability. So they passed initial muster on inspection, but then if you look at the one that was made 6 months ago and the one that was made today, you can have more than like 4 times a difference in how much was actually included. And the other thing that was scary was that they said that in more than 70% of them, I think 26 additional quarter of them were found to contain serotonin. So serotonin, like you're basically taking an adjunct antidepressant, and if you're already on an antipsychotic or an antidepressant, like this could possibly cause serious side effects. So I think that for me is kind of worrisome. I haven't seen these issues with some of the common brands in Canada, like Jameson and stuff, but I don't have specific recommendations on which one to take. I would just caution you to really do your research about the recent analyses of the one you choose. So our guidelines are still in effect when I do use it. I tend to use very high doses, and this is more for my cluster headache patients. And I do find it useful as an adjunct for them. We start 3 milligrams about an hour before bed, and then every week they go up by a little bit, another 3 milligrams, until they reach somewhere 9 to 12 milligrams per day. And I just have them watch it for a few months and see how things are going. Some people feel kind of loopy or dissociated or strange and off, and it's just not the right drug for them. But I do have patients with cluster who go as high as 24 milligrams. I've seen anecdotes of up to 30 milligrams, and that is really off-label. So that's something that's not recommended by Health Canada, but when we're trying to, get a cluster headache under control that has failed to everything else, I think it's a reasonable choice to discuss as a specialist. Other supplements and nutraceuticals sometimes touted for migraine. I mean, vitamin D is probably a very good one. The vitamin D receptors are all throughout our brain in different areas, and they're mainly located in neurons and glia inside the nucleus, but sometimes on the cell membrane. And they're involved in neuroprotection, transmission. They affect the way we make serotonin, which is important, and they have an anti-inflammatory effect. For sun exposure, you probably need 5 to 30 minutes per day, and this depends on a lot of different things. How much of your skin is exposed? What elevation are you on? How reflective is the surface you're on? There's a lot of different factors, and you can actually find calculators online if you want to try to calculate how much you need. The reality is that most Canadians are not getting this kind of sun exposure. They're not going up naked on the roof for 20 minutes every day to get enough of their vitamin D. So, especially in the context of perimenopause, in terms of your bone health, hair, skin, and nails, and everything, it makes sense to supplement vitamin D. There was a nice meta-analysis here of the effects of vitamin D on migraine, and they included 10 observational studies and 2 good RCTs, and they found that the level of vitamin D was significantly lower in migraineurs than in non-migraineurs. So that's kind of an interesting signal, deserves some more study. And then they found that when you did supplement oral vitamin D, it seemed to reduce migraine frequency, but not the duration or the severity. It's not presently mentioned in our guidelines. The other thing that you will commonly hear is like, oh, should I be taking vitamin K2? And there's mounting evidence to support the idea that D supplements should be paired with this in order to prevent calcification of the arteries. So you probably know if you take it that vitamin D is really important for calcium metabolism, and we want to make sure that the calcium is getting into the bones and not into the lining of your arteries. It's very easy to take. I recommend 1,000 to 2,000 units if you are not deficient. Okay, if you have a deficiency documented on your blood work with your family doctor, they will guide you on how much to take. We saw a lot of bizarre stuff happening through Facebook and TikTok during COVID. People were taking 10,000 units. That is not recommended. It can be toxic. You can end up with hypercalcemia, too much calcium in the blood. And this, like, I have patients with like a twitchy face and their nerves are twitching and everything, and they're quite fidgety because they're toxically hypercalcemic. And so I would say, really, not all vitamins are safe. You really have to consult your doctor if you're going to go beyond what's recommended. Omega-3, so the fish oils. I would say a lot of people are including this in their supplements, and it's thought to have an anti-inflammatory effect. For those who have been around for a while, you'll remember we used to sell omega-369. And these numbers refer, like in the chain of a fatty acid, you have a long carbon chain that's kind of kinky and corrugated, and there could be double bonds. And the 3, 6, and 9 refer to the position from the tail where you have a double bond. Okay. And so these omega-3 PUFAs, the polyunsaturated fatty acids, they reduce levels of CNS inflammation in terms of tumor necrosis factor alpha, COX-2, which is the target of many anti-inflammatories, nitrous oxide synthase, and interleukin-1 beta, which is an inflammatory thing. And so we think that in total, perhaps this may be a useful way to cause anti-inflammatory effect. 6 and 9, on the other hand, actually were found to have a pro-inflammatory effect. And so we've seen some interesting studies looking at diets that compare high omega-3 and low 6 and 9. And there's some positive signals, but the truth is we just don't have enough information yet to really recommend that robustly. So there was a systematic review that looked at this, and it basically found that it reduced the frequency and severity of migraine attacks, but not really the duration or the actual scores that we use for insurance to look at improvement. And so they agreed there's a signal there. It probably warrants some more research, but realistically, it doesn't seem to hurt. But there's some concerns about things like heavy metal toxicity and things of some sources, and we'll talk about that in a second. So the omega-3 is not in our guidelines. Usually recommended to take it from dietary sources like having fish twice a week or something. But with farmed salmon and other fishes, there's concerns about bioaccumulation of heavy metals like mercury. Most brands of the fish oil, I will say, are actually quite safe. With levels like, even if they do contain mercury, it's extremely, like, magnitudes of order lower than what is considered the industrial safety standard. And if you're really paranoid about that, you could consider a plant-based omega-3 supplement or krill oil. And you may say, well, Alex, what is a krill? And I thought it's actually a pretty cute little shrimp-like creature found in the Antarctic. And it contains omega-3s that are quite well absorbed. And what I like about it is that it's at the bottom of the trophic pyramid. So when you consider all the animals that eat each other in the pyramid, the predators up at the top actually concentrate all the toxins that the small ones have been accumulating, and that's called bioaccumulation. The krill are at the bottom of the pyramid. Okay, they're the basic stuff that the smallest fish eat. So they aren't likely to accumulate as much of the toxin. And so numerous studies have shown that their oil is absorbed just as well as you would from any other source. And they're thought to have perhaps a little bit less, they don't require the purification process. Other things like that you'll hear in parlance or in blogs and things, 5-hydroxytryptophan, curcumin, skullcap, vitamin E. The truth is, like, I do not have enough evidence to recommend this in my practice. And these may be interesting molecules who also have anti-inflammatory, anti-glutamate positive effects. But this is where we start to get into the gray area beyond what's considered allopathic medicine. And the main difference is your doctor is not trying to hide anything from you, but in order for it to be a recommendation within the standard corpus of medicine, it has to pass a certain threshold of evidence. And so it demands kind of randomized controlled trials and consensus. And so my invitation is this: anything you think is useful, bring it to the forum. Like, I actually am very open-minded. I do psychedelic research. I studied Chinese medicine in China for a while. I think there is value in looking at these other lines of thinking because sometimes there's things you don't want to throw the baby out with the bathwater. If you think it works, bring it to the forum. We're going to design a controlled trial. 2 or 3 people are going to replicate it independently. And if it works, I'm going to steal it from you because I want it for my patients. So I think, it's very great to look at these other spheres of medicine for new targets and up and coming ideas. But to recommend it for my patients, it's got to pass a certain threshold. What about combination pills? So this is kind of all the rage. And I would say you're going to find a bunch of them. There are many, many others, okay? And they all contain different permutations of what we've talked about, and maybe even a few we haven't. And people say, well, what's the best one? And the truth is, we don't know. And more is better, right? But I don't think that's true. I don't recommend any one in particular. If you had to pick one, I mean, 3 grains Canadian. So if you want to help somebody locally, I think that's a nice thing. The decision to start one of these really is a personal decision because often you're weighing convenience and cost, right? I would say you could go to Walmart or Costco and buy a 3-month supply of some of these cheap vitamins for $10. And then maybe you stack them all up, but that means you're eating a whole handful of vitamins for breakfast. If that really annoys you and you don't like to swallow pills, maybe this is for you, but you're going to pay a premium for them to formulate it in a single pill. I would avoid any of them that contain pyridoxine, B6, because as a neurologist, and again, I'm biased because I see the nightmare stories, these are the ones that actually, if you take too much of it, you're going to get a peripheral neuropathy. And it can damage your nerves sometimes irreversibly. I had patients who thought they were doing something really good for themselves, taking extra B vitamins, and they were mega dosing B6, and it caused a toxic neuropathy. And once that's done, the bell has rung, you cannot bring it back. So I've left again, if you want to take a quick screenshot, these are kind of some of the basic magnesium B2, D3, CoQ10 stack that's commonly recommended in the migraine clinic. And recordings of this are always available too through the Migraine Canada website. And I just wanted to give a shout out to this article that came out just before our talk, which is really great, Dr. Tepper. And it kind of gives a good narrative on all the new supplements and a really good I would say a digest of the up and coming studies and things. It's behind a paywall, so unfortunately it's $40 American. But if you want the other one, this one I don't think is behind a paywall anymore because it's older. So those are some good articles if you want to go deeper. And in summary, I want to say, many Canadians and migraineurs specifically may be low in magnesium and D. Most of the nutraceuticals that we recommend have some sort of anti-inflammatory or antioxidative effect supported by basic science literature. It's very patchy though in humans. More research is needed and optimal formulations and dosing. And the effect size of these nutraceuticals, while it can't be ignored, it's a lot smaller than we would expect for some of our more blockbuster drugs that we use for migraine. For now, our guidelines in Canada recommend magnesium, B2, CoQ10, petacites, and very weakly melatonin. And I would just say, beware the predatory supplement peddlers, because as bad as sometimes people think big pharma can be, there's many people who are preying on that counter fear. Everyone from Kardashians to Rogans to everyone are selling weird vegetable capsules and CoQ10 and biotin together for your nails. And, people are making millions and millions of dollars off of this. And I would argue that, it may not be helping you. You really got to do your research. And I think it takes it takes a lot to develop a critical eye for some of this and to really go deeper into their claims. The combination supplements, I mean, convenient for some, but you got to weigh that convenience against the cost because sometimes they're often more expensive. So with that, I would invite you, if you're interested in other things. I know we had some questions about topical oils and, eucalyptus and menthol that came in, but we did a separate talk a while back. It's still recorded on the essential oils and topicals. If you want to look at other things that are non-pharmaceutical, I did a talk on nerve stimulators for migraine, so you could explore that. And this is all available on our site. And with that, I want to thank you.